Hello, thank you for the privilege of the presentation today. This talk is adapted from a debate that I participated in at the scientific session of the American Heart Association in November 2022. The question was, should CABG be Class 2B for improving survival compared to medical therapy in three-vessel coronary artery disease with normal ejection fraction? Well, my answer is a resounding no. And it's not just from me. The STS and the AATS have also voted no, and they were also followed by multiple surgical associations and cardiovascular associations, some of which had cardiology membership as well. Now, if we go back, CABG has always been a Class 1 recommendation in patients with multivessel coronary artery disease or two-vessel disease with proximal LAD, regardless of the ejection fraction, with survival as an endpoint. This applied to three prior ACC AHA revascularization guidelines in 2011, 2012, and 2014. It is also Class 1 recommendation in the 2018 European guidelines, where again, this recommendation applies regardless of the ejection fraction in patients with multivessel coronary artery disease. This all changed with the 2021 ACC/AHA SKY guidelines. CABG in patients with three-vessel coronary artery disease and normal ejection fraction was demoted to a Class 2B weak recommendation based on level of evidence B, randomized evidence, and 4 supporting references were cited, reference 10 and references 13 through 15. Let's go through them one by one and see if those source references and source documents really support the downgrade of CABG or not. Reference number 10 was the Salim Yusuf meta-analysis. CABG was associated with a survival advantage regardless of the ejection fraction. The second study was reference number 13, and CABG again was associated with improved survival in patients with three-vessel coronary artery disease and two-vessel coronary artery disease with proximal LAD disease in patients with good left ventricular function. That is what the authors of the source document clearly stated. But the writing committee of the guidelines argued that those two studies are old, as if they had an expiration date. Medical therapy has improved, and we agree with them, but so did CABG. Now, the CABG state 30-day mortality in the FAME-3 study published earlier this year was 3 in 1,000, identical to that of PCI, and by the way, 10 times less than the mortality rates reported in the Salim Yusuf meta-analysis and some of the older studies. So why was this not factored in by the writing committee of the 2021 guidelines? Why not? Well, then we are presented by the so-called new evidence to downgrade CABG. Let's look at that. The ischemia trial was central to that evidence. And as the name suggests, the ischemia study was a negative study intended to compare initial invasive strategy stipulating a cardiac diagnostic cath versus conservative therapy. In fact, not a single patient was randomized to CABG or PCI for that matter. And of those patients that had an intervention, 3/4 were PCIs. And more patients in the intervention arm received medical therapy than those who underwent CABG. The median follow-up was only 3 years. Now, they published an extension up to 5 years or so, but so what? When we offer CABG, we look at a lifelong therapy. We don't look at 2 or 4 or 5 or 6 years. It's in perpetuity. But despite that short follow-up, 21% of patients crossed from the conservative to the intervention arm. Very importantly, less than 50% had proximal LAD lesions. I cannot remember the last time that I performed a CABG on a patient with no LAD lesions, no proximal LAD lesion. On the other hand, if you look at the typical CABG population, according to the STS database, 92.9% have either multivessel disease, plus or minus left main, versus the 69.5% in the ischemia population. Now, remember again, even within that number, less than 50% had proximal LAD lesions. These patients are rare. This population does not represent a typical CABG population. This steep difference in the atherosclerotic burden is manifest in the clinical risk profile of the STS CABG patients versus the ischemia-like patients. CABG patients are more likely to be diabetic, hypertensive, and smokers, and 2 to 4 times more likely to have cerebrovascular disease, peripheral vascular disease, or heart failure. In reality, CABG patients have more advanced coronary artery disease, and there's little overlap between the typical ischemia population and the typical modern-day CABG population. So how could ischemia inform decision-making about CABG? It can't. Now we'll look at reference number 15, the Bangalore meta-analysis. It excluded patients with heavy atherosclerotic burden. 16% of interventions, only 16% were CABG, and half the trials incorporated did not even have a CABG arm. This is inadmissible evidence when it comes to indications for CABG. In summary, here's the evidence appraisal regarding the downgrade of CABG. 4 supporting studies. 2 clearly demonstrated the survival advantage for CABG, and 2 so-called new studies were not designed to compare CABG versus medical therapy and did not incorporate the typical CABG population that we operate on nowadays. The writing committee of the 2021 guidelines failed to appreciate the concept of lead time bias and extrapolated findings from lower risk populations with low event rates and short-term follow-up. This dilutes, weakens any potential benefit of intervention. There was lack of evidence from the CABG-like population, the other end of the spectrum in this figure. The fact is, the new evidence that downgraded CABG was not based on a head-to-head randomized comparison of CABG versus medical therapy. So I don't know how the writing committee decided on level of evidence B randomized. It should have been level of evidence C, expert opinion. Now, ischemia and the evidence presented was really taken out of scope and out of context and has nothing to do with CABG. The evidence that was presented and the CABG recommendation is nothing but a forced relationship or a forced correlation. However, ischemia and the new evidence does provide evidence that supports perhaps a class 2A for initial medical therapy and close follow-up with revascularization as a future option in patients with multivessel disease and normal EF. This is what the evidence supports, and no one would challenge that. So the facts are that medical therapy is cornerstone therapy for all patients, regardless of whether they undergo CABG or not. Evidence supports initial medical therapy in select patients with multivessel disease, i.e. those who are ischemia-like, low atherosclerotic burden, for example. And the evidence is clear about the effectiveness, safety, and durability of CABG. However, current evidence does not support the blanket downgrade of CABG in three-vessel disease and normal EF. Recently, we published in JAMA Surgery a detailed review of how evidence matters, and that we should always, as professionals, examine the source data and not to blindly accept summary evidence and recommendations that are presented to us. Finally, no one talks about the cost of a baseless downgrade of CABG. Death and adverse events are well documented in patients on waiting lists for CABG. Perioperative morbidity and mortality of CABG are increased in non-elective and low EF scenarios, both potential byproducts of deferral of CABG. So here's an example of a patient in his 50s who had been managed medically for stable angina and multivessel coronary artery disease with normal EF. Now he presents to the clinic with shortness of breath and this MRI. He had infarcted his entire anterior wall and has a large LV thrombus. His EF now is unfortunately 25%. On the other hand, this is an 88-year-old who presented 30 years ago with stable coronary artery disease and normal ejection fraction. And this is his heart cath. He has an occluded right coronary artery and occluded left main coronary artery. He is not living because of advanced medical therapy. He is living because of a patent Lima to LAD that supplies the entire heart through collaterals. If you leave the operating room with a patent mammary to LAD, then that mammary should stay open in perpetuity. We know that because of the biologic properties of the Lima that renders it resistant to atherosclerosis. So at the end of the day, it's all about our patients. And we should be patient-centric in our approach. So the next time you see a patient with three-vessel coronary artery disease, present him or her with facts and ask them if longevity is important to them. If so, then you should choose CABG. Thank you very much.